and welcome back to another episode of A Doctor's Insight. Today we have Mr. Carleton-Bland. So, Mr. Nick Carleton-Bland graduated from St George's School, University of London with distinction. He holds a first class honours degree from the University of Leeds and a master's from Manchester Business School. He underwent basic surgical training in London and was appointed to a national training number in neurosurgery in 2009. He is trained in San Francisco, Sydney, and in 4 neurosurgical units in the northwest of England. He was admitted as a Fellow of the Royal College of Surgeons in 2015 and has completed a 2-year complex spinal neurosurgery fellowship. Since being appointed as a consultant neurosurgeon at the Walton Centre in 2017, Mr. Carleton-Bland has run a full-time clinical practice alongside an educationalist practice. At the undergraduate level, as a senior lecturer, and lead for neurosurgery at the University of Liverpool. At postgraduate level, he's a specialist advisory committee member, past director of regional teaching for the Northwest, and is the current deputy director of medical education. He's a human factors trainer. He has won a national teaching award from the Association for Perioperative Practice, won the Postgraduate Excellence in Education Award 2020 from the Northwest School of Surgery, and was a 2023 nominee for the ACIT Silver Scalpel Award. He's also a husband and father to 3 daughters. Welcome, and thank you for joining the podcast today.
Thank you so much for asking me to speak, and it's a real honour to be here. And thank you for such a lovely introduction. It all seems very very grand when you read it out like that. But I guess, like anyone's career, you just do little and often and start to build a career. So yeah, thank you.
No problem. So can you begin by telling us a bit about your specialty?
So neurosurgery is a speciality that I think a lot of people think they know about, but maybe they don't know the reality. I think the popular culture is, millimeter fine surgical activities within the brainstem of a patient, and I think the reality can be that, but often it's a bit more prosaic. So neurosurgery is a small speciality within surgery. There are about 400 consultants in the UK who practice neurosurgery. And the workload is about 50% emergency and 50% elective. There are a number of different sort of subspecialities, but the majority of the work is spine, trauma, and oncology. They're the sort of 3 big hitting subspecialities within neurosurgery. So some of the most common presentations to A&E, so spinal injuries, head injuries, acute strokes will be referred to neurosurgery. And things like back pain and headache will also be referred to as an elective setting. So there's a huge amount of potential symptoms that we get referred. So I guess that's the sort of the broad sweep of the work that we do. The subspecialties, just to enunciate them. So spine is probably 50%. Trauma and oncology, brain tumors is that's probably about 80% of the work. And then there are other subspecialties, pediatrics, which essentially pediatric neurosurgeons will cover all the main subspecialties, but just for children. And then there's functional neurosurgery, which is a kind of cool putting in stimulators into the brain to help with movement disorders and helping with pain. There's a subspecialty of oncology that just deals with skull-based pathologies. Often they work hand in hand with ENT surgeons. So skull base is a big part of it. There is vascular neurosurgery that is an area that's shrunk from a surgeon's point of view. That's because the interventional radiologists have done and taken so much of that workload. Pituitary is sometimes seen as a separate speciality, so operating up the back of the nose usually to remove pituitary tumours. That's sometimes seen as a separate speciality to general skull base neurosurgery. And I think that's probably most of the specialties that we have.
It seems as though there is a wide variety of subspecialties within neurosurgery. Do you get experience within each of them before you choose which one you'd like to pursue?
Yeah, it's a good question. So it depends on the unit that you're in. If you are lucky enough to train in a large unit, you will encounter most of these. Not every unit has a pediatric subspecialty. Not every unit will have a a functional neurosurgical service. So for trainees within those units, they'll have to actually go and work quite hard to go to another unit to train. There are about 20 across the UK, and the majority of neurosurgical training programs in the UK rotate through a couple of hospitals, but there are a few just standalone units.
And can you tell me a bit more about, you mentioned oncology being a major part of some of the presentations that you see. Can you tell me a bit more about a surgery or a couple of surgeries that you may undertake within a day or even a week?
Yeah, so for a neuro-oncology, unfortunately, the majority of brain tumours that present to neurosurgery are at the very worst end of the scale. So the WHO grading, grade 1, relatively benign tumour, up to grade 4, which is the most malignant, and the majority of intrinsic brain tumours, gliomas, coming from the gluey cells, that's the origin of the term, the cells that they aren't the neurons themselves, but they're the cells that support the neurons, astrocytomas, ependymomas, and so on. They tend to present in the most malignant fashion, which is obviously quite upsetting, because the treatment that we give, it's a mixture of treatments. There is obviously there are medication treatments that we can give, and things like chemotherapy. There are treatments like radiotherapy, but surgery is still a big part of it. One, to make a diagnosis, and two, to physically remove the lump. But unlike perhaps liver surgery or skin surgery or breast surgery, where we can do a very large, wide local incision to excise the tumor, the whole problem with the brain and the spinal cord is that it's a load of linked structures. I mean, the whole brain and spinal cord is designed to carry a message from one part to the other. And unfortunately, the tumor cells very easily slide up and down those axons and spread throughout. So often the goal of surgery is not to completely excise. We can't do that. And so we are effectively palliating the patient. And so the median survival for a grade 4 butterfly glioblastoma is still around perhaps 2.5 years. That's with the current state of technology, even with the new magnetic therapy that we add in for the tumor treating fields, which is a new external invention that we've come up with. Still, it's a pretty dismal picture for neuro-oncology.
Does sound.
So what are those tumors would perhaps occupy half a day's operating? It does depend on the location and what adjuncts we use. There are some advanced technology adjuncts that we use, including giving a special fluorescent dye that help us see the location of the tumor. If the tumor itself is in a non-eloquent area, such as the part of the brain that doesn't help you see, speak, or hear, then we would treat that under general anesthetic. If the tumor is in an area that is eloquent, i.e., it's the speech area or the vision area or what have you, the movement area, then we might do the patient surgery with electromonitoring, or even with the patient awake. And obviously, in those circumstances, we're constantly trying to make that judgment between maximal resection and leaving function. And what we have come to understand is that, and I guess one of the big goals and memes of neurosurgery is to preserve neurological function. That we know we're not going to achieve a full oncological clearance, so we need to remove as much as possible, but leave function. We understand that patients who have a deficit, a new weakness, or a visual problem or a speech problem have obviously a worse quality of life, but actually they live less long. So preservation of the function is absolutely the key to our neurosurgical practice.
And based on what you're saying, it sounds like neurosurgery depends on technological advancements to aid in these procedures. So, how would you describe your specialty from when you first started until how it's evolved currently?
Yeah, I think that's a very good observation. It is a massively techie surgical speciality, and that's is partially due to when you look at the brain, or if you look at the spinal cord, you can't often see where the problem is, and so you need to be guided there. And so I think that as a speciality, the major step forward. I mean, obviously the CT scan in 1970 was a huge step forward to be able to image the brain, but the MRI scan in the early 80s, it was brought in to practice. That has really revolutionized how we understand and how we locate the sorry, I just logged off there.
No, that's okay.
I'll start again. So neurosurgery is a massively techie speciality, and this comes from uh, the advancements we've had in CT scanning. So Geoffrey Hounsfield back in St George's introduced the CT scan in the 1970s. That allowed us to really see within inside the skull and see where the lesion's going to be. But the MRI scan has really pushed things forward. That was designed in Nottingham in the 1980s, and that allows us to see the white matter tracts and see where the lesions are, and that's really allowed us to understand the location. Before these inventions, we were purely guided by guesswork and examining the patient and listening to the history to guess where the lesion is. These things have made it possible to see where they are. I think the major advances in my lifetime really is the translation of knowing where the lesion is to within the operating room to be able to actually find the lesion and do something about it. And so neuronavigation, so using a computer guidance system is one of the big steps forwards. Now, when I started as a medical student and I first saw a craniotomy at St George's in 2003, they had for a couple of years had this new cranial navigation system where we load in the MRI and CT, and then we use a computer guidance system to locate it. And this seemed absolutely incredible and space aged. And so that technology has been around for 20, 25 years, but it's become more and more useful to actually perform the surgeries. And now, certainly at the Walton Centre where I'm working at the moment, we've now got a surgical robot that uses that ability to know exactly where the patient is and to navigate, and that now is allowing us to perform surgeries, and it's guiding the surgeries. It's not yet autonomously doing the surgeries, but it's that kind of next step, I think, to a kind of uh, you know semi-automated procedures. We also have a robot at the Walton Centre that helps us place the deep brain stimulator electrodes. So again, a straight line trajectory to bring the electrode very, very super accurately to where we want to place it. So I think those technologies are huge within the operating theatre. I think the other technologies which perhaps are less impressive visually, but are super important, is actually our technology to analyze data and to actually understand what we do in terms of outcome. So previously, a lot of neurosurgery, cranial work, spinal work was based on, and look, this is the scan. We've removed the tumor, or we've put these bits of metal in, or what have you. But there was no kind of nod to how the patient is at the end of it. Are they better? Have we actually, improved their quality of life, their length of life? Have we got rid of their pains, or what have you? And so I think that there's been a big move to move away from radiological outcomes to clinical outcomes. And I think that's across the whole of medicine and surgery. But it's made a big difference, I think, to how we understand the efficacies of our treatments. And I think that we are on an exciting cusp with the datification, because then we can process it with artificial intelligence. And I think that ChatGPT has taken the world by storm and impressed a lot of people with how clever the artificial intelligence is, and how the processing, how powerful that processing is. And I think that medicine generally will be moving in that direction, where we will be training AI algorithms to, we'll train them with tens of thousands, hundreds of thousands of examples, and that will become perhaps the standard for diagnosis. And we have this with Watson, which IBM own, and they trained that in an ophthalmology setting, and they gave 120,000 fundi to this Watson algorithm. And now, if you show the AI a picture of a fundus of the back of the eye, it will make a diagnosis more accurately and more consistently than a human being. And I think that for lots and lots of image-based specialities, so think radiology, think histopath, think X-rays and MRIs, radiology generally, I think that the training is probably happening right now, and will very soon be really, really powerful. And it sounds like pie in the sky, but we've already had it for 20 years, because there's AI in the ECG leads out. When you get an ECG tracing, there's an AI saying that this is abnormal ECG, consider this as a diagnosis. So we already have these decision support tools. So I think it will come across the board. And I think that these areas of growth are going to be really, really powerful. It's going to be great for patients because you as a doctor could have a bad day or have an off day, or even be someone who makes a favorite diagnosis. The AI won't do that. It'll just base it on data, and it will continuously add um, to its knowledge, and so it'll just get better and better and better. And it may be that we give most MRs or most histologies to the AI primarily, and it only flags up if there's an issue. So I think that my speciality, neurosurgery, has benefited hugely from imaging, and then the accuracy has been improved by robots and so on. But I think the future is going to be that processing, that post-processing by artificial intelligence. Wow, how exciting!
It's impressive, isn't it? And I've heard a few conversations about AI and its impact in medicine in the future. And it seems like a lot of people are confident that will have a positive impact on patient care and patient outcomes. But I heard an interesting point raised by someone who is quite concerned that it's going to negatively impact the clinical acumen and diagnostic skills of doctors. How would you respond to that?
100%. I mean, I think whenever something comes along which is so accurate and so powerful, um, unless we're careful, unless we continue to educate, then you could get de-skilled. And I think that's one of the concerns about the surgical robot, that the majority of the pedicle screws that I will put into a case will be guided by the robot. It makes it super accurate for the patient, makes it very unstressful for me because it's so super accurate. But the surgeons in training don't get the opportunity to kind of learn their craft. But you could argue, against that counter narrative, that is it moral to have surgeons who aren't fully trained kind of practice their craft on a, even if they're supervised, practice their craft on a living person? Maybe we should have everyone get to a level of excellence on a simulator or on models before we unleash them on the public. And you could always analogize it to the aviation industry, that you have to do your flying hours on the simulator, you have to pass everything, you have to take on critical moments of engines burning out, and maybe with better technology we'll be able to simulate a lot of operations and actually qualify almost primarily with simulation before we are sort of let loose on patients. And I think that patients would kind of expect that. Using that aviation analogy further, we don't fly on autopilot all the time. I mean, we do, but certainly the pilots keep their skills up. They will take over flying, they will land, and they will take the plane off. They won't always use the artificial intelligence for that. And so you would have a responsibility as a surgeon not to sit there, feet up, reading the paper. You would actually have a responsibility to maintain your skills. And so, yeah, I understand that. That concern, and I think that's where we as educationalists really need to step in there to ensure that the teaching is good, that the simulation and the advanced education is there. So yeah, so I accept that, but I think that the overwhelming benefits of this technology is there. So if you're in Glasgow, or if you're on the Isle of Man, or if you're in the south of England, somewhere leafy, you get the same high quality diagnosis and surgical or medical care. It shouldn't be based on individual variations or hospital variations. And I think that in the NHS we have a very exciting prospect that there's no financial constraints to not have all 65 or 70 million people's health records combined in a way to make a very, very powerful um, uh, data set on which to train these decisions. So I think, yeah, it's exciting, but there are definitely concerns. And I guess some of the concerns with the data sampling are the kind of concerns that we have with randomized controlled trials now. That tends to be young, white, male college students who volunteer their time for a lot of these randomized control trials. And that is not a demographic that represents the entirety of the patients we're treating. So I think actually the big data, because we'll have much bigger numbers, will actually get better granularity about how the treatments work for specific demographics, ages, what have you.
Yeah, definitely. And it's all about representation and making sure that the demographic of patients that are treated is actually not treated, sorry, that we look at in terms of sampling is actually representative of the population of patients that doctors see and actually treat.
Yeah, yeah.
So, can you tell me a little bit more about your favorite part of the specialty? Because I know we talked a lot about the presentations you may see, the tech, the advancements in AI. So, what do you really enjoy about it?
Yeah, I mean, I think it's a fantastically interesting speciality. I think the 50% emergency is always exciting. There's always a story behind how an injury or something happens. So there's an interest from the point of view of, on a human scale. Um, and I think that the interest over perhaps other acute surgical specialties like ortho or general is the diagnosis. And I really love the fact that neurosurgery, that there is, there's that sort of academic problem solving, almost detective work, that the wiring diagram of the brain, the spinal cord, the peripheral nerves, and you have to try and relate what you know to the clinical presentation and say, where the lesion might be and what the nature of the lesion might be. So there's still that kind of academic interest and that you get. So I really like that. And obviously, like all surgeons, we have a very tangible outcome. I think with medicine, occasionally you will get that very quick and swift and very effective treatment of a condition. But really, surgery, that's where you get it par excellence. And that for you as an individual is very, very rewarding to learn the anatomy, to learn how to perform the surgical skills over multiple cases, to watch videos, to go away to courses, and then be able to bring all that together, to be able to communicate to the patient, to be able to take good consent, and then to be able to deliver the surgery and then have a good outcome. It brings together so many threads of skills that you've had to acquire. And it is massively satisfying to be able to put that together and to be able to help a patient. And in neurosurgery, obviously we remove spinal cord tumors or brain tumors, but the things which are seen as perhaps little, like helping a patient with awful radiculopathy, that's not tiny. We recognise that radiculopathy is a huge burden of disease. Perhaps 10 to 50% of the population at any one time have horrible shooting pain in their arm or in their leg. Well, this is awful for them in terms of living their life, looking after their children, going to work, being on medication, even sleeping. And so we recognise that from a small operation, perhaps taking an hour, we can get rid of pain for that patient, allow them to get back to living their life, to get off the medications. And certainly in terms of quality adjusted life years, we understand that treatment of radiculopathy is in the top 3 of all surgical interventions. So we've got a very broad and interesting speciality, lots of emergency work, which is fast paced and quite interesting. There's lots of clever chin stroking, kind of neuroanatomy things like the functional neurosurgery and so on, which appeals. And then fundamentally, the interventions that we do can often have big, important improvements in the patient care, and kind of being there for patients when they are, in a bad way. They've had a terrible polytrauma, head injuries, spinal injuries, and we're there to help, piece the patient back together. So I think there's a huge amount of satisfaction. Um, and I think in addition to that, like all surgery, not just unique to neurosurgery, there are so many opportunities to have a parallel career. So for me, very much education is my thing. It's what I really love. But you can be a really great researcher. You can be a great leader or a manager, alongside with a specialty. And so I think it just gives so much opportunity for you to find that niche where your skill set really matches, those areas. So I think it's awesome. Yeah.
It sounds like it's very fascinating, and I like that you highlighted there's a variety of things that you can do as a neurosurgeon. So you have the ability to communicate with patients, but also practice those surgical skills. And then neurosurgery seems to be at the forefront of tech advancements and things. So that's quite exciting as well.
Mm.
On the flip side, if there's any answer to it, what's your least favorite part about the specialty?
Well, yeah, I mean, I think the what I've alluded to before. I guess one of the most common presentations to neurosurgery would be a malignant brain tumor, and the fact that all of what I've talked about, all the tech and all the skills, still fundamentally hasn't made a huge difference to survival. And I think it's those patients that you can't help, and uh, we receive patients with very bad brain injury, and there are things that we can do. We can, remove blood clots, and we can stem bleeding, and we can remove sections of bone if the brain is swelling. But fundamentally, the fundamental biochemical cellular level problem for trauma and for tumors, surgery is not probably going to be the answer. And I think that, for tumors, I think it's going to be immunotherapy is probably going to be the way we're going to crack that one. And I think for neurotrauma, well, probably primary prevention, everyone driving at 30 and wearing helmets is probably going to be the best way to cure that. But in terms of secondary things, I think that's going to be a biochemical phenomenon, and it's not for want of trying. Obviously, we have been looking as a profession for years and years and years for that tool, but I think that breakthrough will come as well. But I think that we can only achieve so much in terms of our intervention, and that is a frustrating thing, that patients who are too badly injured, or patients who present with tumours, we can still only buy them a relatively short amount of time, and I think that's probably the hardest thing to deal with.
It sounds like it can be quite disheartening as well. So how do you navigate that when you meet a patient who has potentially a stage 4 that you have to palliate?
Yeah, it's really awful, and I think that there is no easy way to do it, and I don't know. And when you speak to a medical oncologist, it'd be interesting to hear how they deal with this continuous tragedy. And it is a tragedy. You have to tell a patient, as I did, about what the histology is, and one of the questions will be, right, well, how long have I got to live, doc? And it's awful to have to say, well, we don't know, but we're measuring it in months rather than decades, and that's reality. That is hard to say, and obviously we have lots of mentoring for communication skills, we have lots of practice, but the reality is it's hard to tell a patient face to face that they've got this condition and they are going to die from this. And so that's hard for them, that's hard for us. And I think that we if we don't process this kind of sadness and difficult situations, I think it could lead to burnout. And we know that burnout in medicine generally is a common, and probably one of the most common reasons to leave the job. And so we have to process this. And I think that the world has changed, and the kind of stiff upper lip and just get on with it and whatever has gone. And I think that people are a lot more open. And there is counselling, and there's lots of other services there. But probably the best counselling that you receive are colleagues, because colleagues have been exactly in your shoes. They have true empathy with how bad it is. And I think that release and that discussion is one way to process and to deal with what is very difficult for you as a practitioner, because obviously it's hellishly bad for the patient, but you're having to perhaps give this diagnosis, as I would do, perhaps 5 times in an afternoon, and that takes its toll. And you have to this is like resilience. You have to build resilience. Well, yes, you do, but you're a human being, and you don't want to become a detached, distant person. But I can understand why people become like that, because it's self-protection. But I think it's that middle ground of really having empathy, feeling the hurt, but also being able to process it and not take it home with you. And I think that's a real skill, and I'd be interested to hear your podcast with oncologists and people who do this as their entire job, because it certainly takes its toll on me when I am in that situation.
Based on the other clinicians that I've spoken to, they've all said something similar, which is that you need to talk to your colleagues, and it's really important to have a supportive team around you in order to help navigate and deal with those feelings when they do come
Mm.
up.
Absolutely, and I think that's one of the reasons to foster those good relations with your colleagues, because you are there for each other, and you are such great support, better than anyone else you could really speak to, I think, or anything else you could do, is to share, because almost everyone you speak to has been in a similar situation. But I think if things were really getting to you, and I found pediatric neurosurgery as a subspecialty really, really harrowing, and I recognized it, because I had, I thought of it as a potential specialty. I recognized it, and I recognized that I couldn't do that job. I would find it too upsetting, and I think that I would, have a foreshortened career, or I would become very hardened potentially, and that's not where I wanted to be. So I think, reflection. We always talk about this in training. Oh, reflection, but it has genuine uses, dear listener. It really does, and it does. I think allow you to have a forum to look at this, and in the cold light of day to discuss it, and it'll help you hopefully make wise decisions about where you're headed in your future.
So there are a lot of things to consider when thinking about what specialty you want to pursue. What resource would you recommend to junior doctors or even medical students who would like to get a comprehensive perspective of neurosurgery?
Yeah, I mean, I think that yeah, people have a lot of pre-existing ideas about what neurosurgery or what cardiac surgery or whatever the specialty is, what it's like, and one of the big things that we look at when we're interviewing and when we're selecting for national neurosurgery selection is that the person doesn't have a Grey's Anatomy view of neurosurgery, but has a very realistic 3D concrete view of what the realities of the specialty is. The only real way to get that, I think, is to do a decent length observation, not a day, but a number of weeks at a unit, or perhaps at a couple of times within their medical student or junior doctor career. It gives documentary evidence that they have a good idea of the speciality, but in reality, you see what it's like, and you see the highs and you see the lows. And I think as a medical student, when I went through looking at the various specialities and trying to decide where I was going to go, the placements that I had was super useful to kind of look at that. What are the highs, what are the lows, what do I want to do with my day, um, or do with my week? What's it going to look like? Because obviously the academic reading the books or watching the videos is only just a snapshot of the reality of what it's like to do a job. So I think, yeah, I think that it's great to watch the videos and go in the courses, but I think a sustained placement to observe the speciality is got to be the key, I think.
And there's so many specialties that you could have chosen. So why neurosurgery?
Yeah, so I when I was a medical student, enjoyed every single speciality. I found the academic, the studying, the questions. I found everything interesting, and I really didn't know. And I really quite liked ITU, and all playing with all the sort of physiological parameters and intervening. But when I did a surgical placement, which was cardiac surgery, I really thought that, yeah, I like all of the acute physiology and the knowledge base, but I actually like doing things with my hands. I'm quite sort of an activist. And I enjoyed all sorts of surgery again. But with neurosurgery, it had that, as I said, that appeal of the real complex anatomy, the detective work, and surgery, and so it had basically a little bit of everything that really appealed. Um, so yeah, I think that was probably what appealed. And I saw Henry Marsh do the very first neurosurgery I saw was Henry Marsh doing a craniotomy for a tumor with Equinox blasting out in a beautiful Edwardian mansion house in Wimbledon Village. So it was such a heady
Wow.
cocktail of impressive. It made a massive impression on me. And I think when you first go to surgery, the lights, the bright lights, the drama, the smells, everything is so intoxicating. And to see the brain thumping away there, and then to see the brain opened up carefully and the tumor resected, this just absolutely blew my mind. So I really did have that very classic kind of absolutely amazed by the surgery. But the rest of my placements, I actually found all the other stuff, the examining the patients and the making the diagnosis, interesting as well. So for me, it just combined uh, all the interesting stuff together.
And what is the actual training pathway like?
Yeah, so it's an 8-year training pathway. So you do your medical school and then foundation, and then at the end of F2, you can apply to an 8-year training program, ST1 to 8. The way that we select for neurosurgery is based on a competitive entry. I mean, it's very similar to lots of other medical specialties. You do the MSRA, the sort of the general medicine qualification. You have to score well on that, but then also you have to show commitment to the speciality. It's useful to have done some of the surgical courses, and it's useful to have shown some sort of dedication towards neurosurgery, perhaps with closing a loop of an audit or research or what have you. um, that you then apply, and you're asked the usual kind of questions where you have to try and anticipate how to score highly in the application form, and then you're interviewed. And pre-COVID, we were doing dexterity tests and looking at the operative skills, the stitching skills, and 3D skills. Post-COVID, we haven't yet gone back to doing a physical assessment, so it's very much a Zoom style interview, looking at motivation to enter the specialty, dedication to the specialty, and perhaps looking at the knowledge base and looking at how that individual has kind of prepared themselves to problem solve and to think on their feet. And so that's the selection process. And then we have three big chunks of training. We have phase one, which is the ST1 and 2 years, which is the general kind of neurosurgical training, including doing something that isn't neurosurgery, like A&E or perhaps ENT surgery or some other allied speciality. Some people do radiology, some people do intensive care, but something that gives you that grounding of a good acute doctor with neurosurgery skills add on top of it. And then the second phase of training is really your general neurosurgery, where you become conversant in trauma and hydrocephalus, tumours and spine. And spine is such a massive part of what neurosurgery does. It's probably 50% of the consultants and perhaps 2/3 of all the workload. There's a lot more requirement in the second phase of training, ST3 to 6, I think it is now, to get spinal competencies. And then the final year or so of the training, the phase 3, is really working on that subspecialty interest. So if you want to do, vascular, or if you want to do hydrocephalus and trauma, that's where you really focus on those specific operations, and perhaps go to do a specific kind of fellowship within the training scheme. Now, you may have heard, or you may not have heard, that in neurosurgery generally we've kind of over-recruited for the last decade, and there are a huge number of trainees who've been through medical school, foundation, ST1 to 8, and then don't have a job at the end of it. And unfortunately, there are lots of rules that I won't go into now, but there's lots of reasons why that's occurred. So for this group of doctors, obviously they are committed to neurosurgery and they're trained, and so what is usually done then is perhaps to do an extra year of fellowship, and that can be done abroad. It doesn't have to be done abroad, it can be done in the UK, and perhaps 1 or 2 years of fellowship to really allow you to gain those extra clinical skills. Some people will go out and do some research, maybe do a PhD to if they're interested in academia and they feel it might enhance their appointability as a consultant. And so so it's a long slog. It's a long slog. There's no getting away from it. It's not. It's ourselves and orthopedics, I think, are some of the longest trainings in terms of those years. So that's a sort of slightly prolonged snapshot of the training pathway.
So that was very detailed, and I'm sure people will appreciate that. It sounds quite exciting, but as you said, long and intense. So what would you say are some of the personal or professional sacrifices that you have to be mindful of when going into neurosurgery?
Yeah, I mean, I think you definitely do, and it is absolutely an ultra marathon and not a sprint. And so I think that you have to, as we talked about before, you have to have some time in the specialty. If you're not someone who, is that interested in doing anything apart from, deep brain stimulation, then neurosurgery is not for you, because that's only a very, very small area. And there's lots of general surgery to be done. There's lots of, spinal decompressions. There's lots of decompressive craniectomies. There's lots of kind of surgery that we need to do, and we do sometimes get a very, very academic-y type of person who doesn't really like operating but likes the idea of neurosurgery, and neurosurgery really is surgery, and so you do need to have someone who has a mixture of skills of the academia but certainly of the surgical skills. So I think that you need to have time within the speciality to make sure that this investment of your time and your money and your lifetime is kind of worth that weight. You need resilience, as you do in every speciality, and I think that alongside of that is really having that support and having a good support base, having family, having a partner, and children who are understanding. And I think I was very lucky. I met my wife when I was 20, when we were both students, and so she has kind of grown up with me doing loads and loads of weekends, lots of night shifts, being tired, not being present to do things. I mean, I don't want to over egg the pudding. European Working Time Directives has been one of the most beneficial changes that we've had to allow us to have a family life. 48 hours a week mean that you can be home and you can see your children grow up. But it obviously counterbalances that. It makes it 8 years rather than perhaps 5 years. And the numbers of surgeries we see is probably less with EWTD. And that's why we need to be educating and simulating to allow our surgeons of the future to have some family life as well as be well trained. And so I think that is a consideration. And when you look around and your friends who are doing banking or I don't know, accountancy are getting company cars and having very nice lives and having their weekends off, you are not doing that. You're going into with a potential 15-year from the beginning of medical school to become a consultant neurosurgery, 15 or 20 years maybe. You are a junior doctor. That's an awful term that I don't like, but you are a junior doctor. You're not paid wonderfully well, hence the strikes that we're seeing now. And you're working lots and lots of nights and weekends, and you can look around and think, who else is doing this kind of level of input? So that these are all considerations, because if you are a bit meh about going into neurosurgery, well then 8 years is a very, very long time to not earn very much and to do lots and lots of nights and weekends and to not see your family as much as you would like. So I guess I don't want to over egg it, and I think the other question I often get asked, you may be about to ask me about women going into neurosurgery. It is possible. There is a lot more in the way of, well, in fact, it's a blanket rule that if you ask for less than full-time training, the employer has to give it you, which is fantastic. So it's no longer the case, oh, I don't want to ask, I don't want to ask, could I go down to 3 days a week? Could I do a master's degree? Could I, have children, have maternity leave and come back? All of these things are absolutely yes, yes, yes. And women in neurosurgery to carry on with that, it is still quite low. I mean, we know that females make up more than half of medical graduates, but we only have perhaps about 10% consultant neurosurgeons are women. So there's a lot more to do. That may be a generational thing which will alter, or maybe the kind of perception of being at work all the time and so on might go against the perceptions of, could I have a family? Could I do less than full-time training? Well, we have consultant neurosurgeons at the Walton Centre who have done exactly that. So it is possible to do. Is it really easy to do? No, I'm sure it isn't. And when I have my days of childcare responsibilities, doing the school run and so on, it is difficult. It's a lot easier as a consultant to do a drop off or to do a pickup or to juggle around your day. It is less easy as a registrar or a doctor in training, but these things are doable. Again, circling back to having really good working relationships with your colleagues. There's always a way to get around these issues if need be, but you need to have that really strong working relations with your colleagues. It's absolutely vital for you to function in the specialty or in the hospital more generally.
You absolutely read my mind, because I was going to ask you about women in neurosurgery. So thank you for answering.
Well, if you're thinking about it, we'd be very, very happy, because I think that it's a specialty that needs to really expand up and I think it is to an extent, but yeah, no, it's absolutely open. And I'd need to look at the figures, but I think we had I think a 25% female appointment rate, I think, last year. So that's still not 50%, but we are certainly headed in the right direction and really reflecting the medical school workforce in our consultant and neurosurgical trainee appointments.
That's reassuring to hear. So we talked extensively about neurosurgery, but just going more generally as we close the podcast into advice for medical students and foundation doctors. So what would you say to those students who may be feeling a bit overwhelmed at this point in their career?
So you're feeling overwhelmed by just by doing the medical degree, or feel overwhelmed in terms of where am I headed? What do I do? Or
Yeah, where are they headed? Their prospects in the future?
yeah, I mean, I think that is a concern. I mean, I think that medicine generally is an incredibly portable and useful degree to have, and I think that even outside of medicine, having a medical degree is very classically, say for the city and investment banking. I'm not suggesting all your podcasters ditch medicine and go and work in investment banks, but it's a degree that's very well recognised, because to get onto a medical degree and to complete it, you will be in the very top kind of echelons of hard work, and will know how to study and will have very good interpersonal skills and time management skills. So it's a very useful degree as a marker. I think within medicine, generally, it's it is hard. And even though getting a ticket to go to medical school sounds like, oh, all your worries are over, it's a very long slog. And there are lots of demands made, and demands in terms of relationships and money and living your life and studying. So I think that trying to trying to just really de-escalate those feelings, and just really getting your head down and getting through one thing at a time is the way to do it, to kind of chunk it into, I'm just going to work for the next exam, or I'm just going to work and enjoy the next topic. I'm going to maybe take a day to think about what I want to do for my elective, and I'm going to do something about it a year in advance or 9 months in advance. I'm not going to just put it off and then have no elective arranged. And so I think that time management, they always say this, but it's genuinely true, will reduce those stresses. And I think as regards getting through the exams, well, medical school is still, we are all there. Speaking as a senior lecturer at Liverpool, we're all there, and we spend all of our energies to maximise the education and to maximise the chance of getting through medical school, or not just getting through, but being excellent and really being ready and prepared to work as a junior doctor. Being a junior doctor, again, I shouldn't be using that term, but a doctor in training, is tough. It is, but it is a time limited thing. And I think that when you reflect, looking backwards, your transition from primary school to secondary school, big school seemed very scary when you were a year 7. And it was scary, wasn't it? But you got over it, and then you became a year 8 and you had your strut. And that's exactly what you get when you go from a foundation doctor to perhaps an ST doctor. Yes, the responsibility goes up, but you also learn and you get better and better, and you are not alone. And that peer support and support from your senior doctors will be there to make that a thing. I think the other thing that medical students and certainly junior doctors are concerned about is where do I head to in terms of career, and I think it's easy to get very caught up and look around and find one person who's published 100 papers and has started their own medical journal and has been nominated for a Nobel Prize, and that is just not realistic, and that is not required to get into orthopedic or neurosurgical or cardiac or neurology, or you don't have to be the finished product. What you should do is really show that interest and do one thing a year is what I tend to recommend to all the medical students. One thing. An audit, perhaps in an area that's vaguely oriented. Do a closed loop audit, that's even better. Do a placement, perhaps attend a webinar or a course in that speciality. If you can get involved with a project and you get your name onto something that's been presented, you can present it yourself, or even if it is published, that's great. I mean, that's great. It is not an absolute requirement. So I think just do one thing a year, because you very quickly, if you're a 4th or a 5th year foundation 2, you might have 4 or 5 little things you can put in your CV that show that interest, distinguish you as someone who makes that effort. And so I think that those one thing a year kind of strategy is probably what you need to do. I do acknowledge it's a lot harder for medical students now and junior doctors now than it was in my day. I decided on neurosurgery really late as a SHO. And I think nowadays, if you want to go into very competitive specialities, that you need to probably start that process as a medical student, unfortunately, because it's just so competitive. People are constantly thinking about where they're headed. How the heck as a medical student that you want to become a dermatologist is beyond me. But I think if it's there as an interest, I think that you can do that, and working smart. So for instance, for me, I enjoyed orthopedics, I enjoyed neurosurgery, so I did my sort of little bit of interest in spine, because spine is in both orthopedics and neurosurgery. And if you were going to do I quite like orthopedics or plastic surgery, do a hand project or a hand because again that has the crossover, and I'm sure in medicine there's lots of very similar examples where you can do one piece of work that actually you could talk about for a number of different potential specialities or training pathways. So yeah, it's a hard slog. It is 100%, I think, worth it. And anyone who doesn't tell you that working as a consultant is not a load better than working in training is I think incorrect. I think it is much better. And it is great to work as a consultant. There are other pressures that are really difficult to deal with, but generally speaking, it is a much nicer life. And so it's really getting your head down and continuing on and planning what you're going to do. I think is the final thing I would say about that.
So being proactive and understanding that it will get better.
Yeah, I think it is, and it's sad that we have to say it will get better, like we're giving up and saying, well, just being a junior doctor is just a very hard time of your life. But it is necessarily, because you're going from a 5 or 6 years of sort of receiving information and processing it, and then suddenly the next year, F1, you are processing, making decisions, putting your name to it, and making clinical decisions on patients. And so the learning curve and the responsibility curve is a big jump, and junior doctors now are massively better supported with allied professionals, prescribing pharmacists. Decision support software like the AI type stuff we're talking about still doesn't make it any less kind of stressful. And so as that learning curve flattens, you feel more in command and you feel more comfortable with where you are. But unfortunately, and this is across all professional activities, my wife's a lawyer, and she found this too, that when you start a new area of law, you're back at the beginning and it's hugely stressful, and it is just the nature of being a professional in a high stakes, complicated environment. But that learning curve flattens, as you will remember in anything that you learn. And when you're going through your late registrar years as a consultant, it's rare that you haven't seen this kind of thing before. And ultimately, we are like an AI algorithm because we are pattern recognition. I've seen that before. That's what we did. That was the outcome. And you learn and you learn and you learn. That's what wisdom is, isn't it? It's knowledge and experience put together. That's wisdom. And you become quite wise as a senior reg and quite wise as a consultant. And it makes it easier and more manageable.
And now for our closing question. So, what is the best piece of advice that you have been given that has shaped you as a clinician?
Well, I think is it advice or was it support? I don't know. When I were a lad, back in the early sort of noughties, surgical training, if you didn't go from job to job to job to job to job in a teaching hospital, you were toast. Especially in London, it was so obsessed about going from teaching hospital to teaching hospital. And if you went out into the sticks, that's it. Oh, I'll never get a job in London. And I, around the time of modernising medical careers, you may not remember that, but modernising medical careers came in, and it completely changed the way that junior doctors were employed and the way that they were appointed. So it was a huge change, and essentially we as junior doctors had very little insight into what our future was going to be and where our next job was going to be. And so in a sort of fit of, I wouldn't say annoyance, but in a kind of, what's the point? I decided to go traveling. It was part of, actually, I got married, and for our honeymoon, we did a 6-month traveling around the world. How wonderful. And went to
Oh,
Thailand and
cool.
Japan and Australia. Wonderful time. But
Incredible.
yeah, no, it was an amazing thing to do. And I think that the issue is with it that had that been in the 1990s, I think my surgical career would have been very, very difficult to come back from taking 6 months out. They always used to ask you on your application form, have you taken more than 4 weeks out? What was the reason? And I was told that if you had any reason, that was it. You weren't going to be committed to surgery. Well, I came back and I applied to a surgical training, and I was interviewed by wonderful director of surgery, Suana Body, in London. And in the interview, she brought up, oh, I see you went traveling for 6 months. And I just had this absolute feeling sick. My stomach dropped. Oh no, this is it. This is where my surgical career goes over. And without even missing a beat, she said, that's absolutely wonderful. I went traveling to, wherever. What was it like? Was it fun? And not only did she say, do you know what, it doesn't matter that you've taken 6 months out and you've lived your life. It doesn't matter. It's actually a positive. I think that for me was one of the most kind and wonderful things. I mean, obviously I got on to get a surgical job and began my journey, I guess, into surgery. But that for me was just a transformational change, really. The old surgery, I would have been out. New surgery, we encompass, diversity, doing different things with your career. I was a graduate entry student, so I hadn't gone to medical school at aged 18. I'd actually gone there later at 22. That would have potentially counted against me in the old kind of guard. But in the sort of modern world, didn't matter that I'd been to graduate entry, didn't matter that I'd had 6 months out traveling. It was only seen as a positive. And the rest, as they say, is history. So I would say that if you have listeners out there who are thinking of taking time, um, do not see it as a negative. You must live your life. You only live once, and so these things are accommodatable within, training to become a neurosurgeon. You can do it.
And I think more and more with our generation, we want to take time to explore other interests. So that is a very relevant piece of advice that I will definitely take away, and hopefully the listeners will too. um,
Take a break. Just go take a break.
take a
It's
break.
great.
Thank you so much for speaking to me today. That was an interesting conversation, and I now come away having learned more about AI and neurosurgery, and I'm going to think about it a lot more than I have in the past. So
Lovely.
thank you so much.
What a heady cocktail to process. Well, thank you very much, and I've really enjoyed having a good chat. And yeah, and hopefully this podcast is going to be useful and will hopefully change a few minds and hopefully get a few more people to consider my speciality as a career.